What are the key components of the innate and adaptive immune systems, and how do they differ in their response to pathogens? Answer: the immune system is divided into two main components: innate and adaptive immunity. Innate immunity characteristics: non-specific immediate response. Components: physical barriers, skin, mucous membranes, chemical barriers, antimicrobial, peptides, enzymes, cellular components, phagocytes like macrophages and neutrophils, and proteins. Complement system. Mechanism: innate immunity acts within minutes of pathogen exposure. It recognizes pathogen-associated molecular patterns (PAMPs) using pattern recognition receptors, leading to inflammation and phagocytosis. Adaptive immunity characteristics: specific delayed response. Components: B cells produce antibodies and T cells, cytotoxic T cells and helper T cells. Mechanism: takes days to develop. Upon first exposure to a pathogen, adaptive immunity generates memory cells, allowing for a quicker and stronger response upon subsequent exposures. Key differences: speed: innate immunity is immediate, while adaptive immunity takes longer to develop. Specificity: innate immunity is non-specific, adaptive immunity is pathogen-specific. Memory: adaptive immunity has a memory component providing long-lasting protection. Relevant guidelines: understanding these components is crucial for implementing vaccinations, which aim to stimulate adaptive immunity. Discuss the pharmacokinetics and pharmacodynamics of a commonly used antibiotic, amoxicillin. Answer: pharmacokinetics refers to how the body affects a drug, while pharmacodynamics refers to how the drug affects the body. Pharmacokinetics of amoxicillin. Absorption: amoxicillin is well absorbed from the gastrointestinal tract with bioavailability around 70–90%. Food does not significantly affect its absorption. Distribution: it distributes widely in body fluids and tissues, achieving therapeutic levels in the lungs, middle ear, and urine. Metabolism: minimal hepatic metabolism are primarily excreted and changed in the urine. Excretion: the elimination half-life is approximately 1–2 hours, and it is primarily eliminated through the kidneys. Pharmacodynamics of amoxicillin. Mechanism of action: amoxicillin is a beta-lactam antibiotic that inhibits bacterial cell wall synthesis by binding to penicillin-binding proteins (PBPS). Therapeutic window: its efficacy depends on maintaining sufficient plasma concentrations to achieve the minimum inhibitory concentration (MIC) for the target bacteria. Mr. Thompson is a 55-year-old male with a history of hypertension and type 2 diabetes. He presents with persistent cough and shortness of breath. After diagnostic tests, he is diagnosed with chronic obstructive pulmonary disease (COPD). What management strategies should be considered for Mr. Thompson, and what are the key factors influencing these strategies? Answer: management of COPD should be comprehensive and personalized, focusing on both pharmacologic and non-pharmacologic strategies. Pharmacologic management. Bronchodilators. Short-acting bronchodilators, SOBAs like albuterol for acute symptoms, long-acting bronchodilators, LOBAs like salmeterol for regular use. Inhaled corticosteroids. For patients with frequent exacerbations, a combined therapy may be considered. Phosphodiesterase 4 inhibitors. Roflumilast may be added in severe COPD with chronic bronchitis. Non-pharmacologic management. Smoking cessation. Essential for all patients with COPD. Use of nicotine replacement therapy or prescription medications can aid cessation. Pulmonary rehabilitation should be offered to improve exercise capacity and quality of life. Vaccinations: annual influenza and pneumococcal vaccines to reduce respiratory infections. Key factors influencing management: severity of disease, assessment using the Global Initiative for Chronic Obstructive Lung Disease, GOLD criteria. Comorbidities: management of hypertension and diabetes is crucial in tailoring COPD treatment. Patient preferences: involvement of the patient in decision-making to improve adherence to treatment. Relevant guidelines: the NIC guidelines recommend a stepwise approach to COPD management, emphasizing individualization based on patient needs and disease severity. What is the role of genetics in the pathogenesis of cystic fibrosis, and how does this impact management strategies? Answer: cystic fibrosis (CF) is caused by mutations in the CFTR gene, which encodes a chloride channel. The most common mutation is FDEL, leading to dysfunctional CFTR proteins and subsequent mucus production issues. Pathogenesis: mucus production, impaired chloride and bicarbonate transport results in thick, viscous secretions in the lungs, pancreas, and other organs. Infection and inflammation: thick mucus leads to chronic lung infections, e.g. Pseudomonas aeruginosa, and persistent inflammation, causing progressive lung damage. impact on management strategies, genetic testing, identifying specific CF/TR mutations helps in personalized therapy and counseling for affected families. Therapies targeting the CF/TR protein, new medications like CF/TR modulators, e.g., ivacaftor and lumacaftor, have been developed to correct the function of defective CF/TR proteins. Multidisciplinary care management involves a team approach including respiratory therapists, nutritionists, and psychologists to address various aspects of the disease. Relevant guidelines. The CF Foundation recommends regular follow-ups and monitoring to optimize lung function and nutritional status, emphasizing early intervention to improve outcomes. Explain the significance of understanding enzyme function and regulation in the context of drug metabolism. Answer. Enzymes, particularly cytochrome P, CYP enzymes, play a crucial role in the metabolism of drugs. Significance in drug metabolism. Phase I reactions involve modifications such as oxidation, reduction, and hydrolysis, often via CYP enzymes, which alter the drug's pharmacokinetics. Phase I reactions. Conjugation reactions that increase water solubility, facilitating excretion. Enzyme regulation. Induction and inhibition. Certain drugs can induce or inhibit CYP enzymes, affecting the metabolism of other concurrent medications, leading to increased toxicity or therapeutic failure. Genetic variability. Genetic polymorphisms can lead to inter-individual variability in enzyme activity, influencing drug response and risk of adverse effects. Clinical relevance. Understanding these concepts allows healthcare providers to anticipate drug interactions and personalize medication regimens for optimal efficacy and safety. What are the common pathological changes observed in heart failure, and how do they correlate with clinical manifestations? Answer. Heart failure, HF, leads to specific pathological changes that correlate with clinical symptoms. Pathological changes. Myocardial hypertrophy. Increased workload leads to hypertrophy, which can be concentric or eccentric, impacting the heart's pumping ability. Fibrosis. Fibrosis occurs as a response to injury, impairing contractility and electrical conduction. Ventricular remodeling. Changes in size, shape, and function of the heart chambers, particularly the left ventricle, contribute to further dysfunction. Clinical manifestations. Dyspnea, due to pulmonary congestion from elevated left atrial pressure. Edema. Peripheral edema occurs due to increased venous pressure and sodium retention. Fatigue and exercise intolerance, resulting from inadequate cardiac output during physical activity. What is the role of public health interventions in controlling infectious disease outbreaks, and how are these strategies implemented? Answer. Public health interventions are critical in managing infectious disease outbreaks through various strategies. Surveillance. Continuous monitoring of disease incidence and prevalence helps identify outbreaks early. This involves laboratory reporting and healthcare provider notifications. Vaccination programs. Immunization is a key strategy for preventing outbreaks of vaccine-preventable diseases. Public health campaigns aim to increase vaccination coverage. Quarantine and isolation. Infected individuals may be isolated and contacts may be quarantined to prevent further spread. This is particularly relevant in outbreaks of highly contagious diseases like Ebola or COVID-19. Health education. Public health officials disseminate information about hygiene practices, symptom recognition, and when to seek care, empowering communities to reduce transmission. Implementation. Effective interventions require collaboration between governmental health agencies, healthcare providers, and community organizations, guided by evidence-based practices and responsive to the specific outbreak context. Describe the importance of ethical principles in clinical practice, particularly in relation to informed consent and patient autonomy. Answer. Ethical principles are foundational to clinical practice, emphasizing respect for patient autonomy, beneficence, non-maleficence, and justice. Informed consent. Definition. Informed consent is the process by which patients receive sufficient information to make voluntary decisions about their care. Components. It includes the explanation of the diagnosis, proposed treatments, potential risks, benefits, and alternatives. Patients must demonstrate understanding and competence. Patient autonomy. Importance. Respecting patient autonomy means honoring their right to make informed decisions about their own health care, even if these decisions differ from medical recommendations. Challenges. Informed consent can be challenging in vulnerable populations or emergencies where patients may lack decision-making capacity. Clinical relevance. Upholding ethical principles fosters trust, improves patient satisfaction, and promotes better health outcomes. Healthcare professionals must be equipped to navigate complex ethical dilemmas in practice. Relevant guidelines. The General Medical Council (DSC) provides guidance on consent and decision-making, emphasizing the importance of clear communication and ethical considerations in patient interactions. What is the significance of the social determinants of health and understanding health disparities among different populations? Answer: social determinants of health (ESTO) are conditions in which people are born, grow, live, work, and age, influencing health outcomes. Significance: health disparities (SDOH) contribute to significant disparities in health outcomes among different populations, particularly those affected by poverty, education, and access to healthcare. Root causes: factors like socioeconomic status, education level, neighborhood and physical environment, and access to healthcare services all play critical roles in shaping health. Implications for healthcare: addressing SDOH is essential for reducing health disparities and improving overall population health. This includes advocating for policies that promote equitable access to resources and healthcare. Clinical relevance: healthcare providers must recognize the impact of SDOH in patient assessments and care planning, implementing strategies that address these determinants to improve health equity. A 30-year-old female presents with severe abdominal pain, and after investigations, she is diagnosed with acute appendicitis. Discuss the indications for surgical intervention and potential complications if treatment is delayed. Answer: indications for surgical intervention, diagnosis of appendicitis. Surgical intervention is typically indicated for confirmed acute appendicitis as the condition can rapidly progress. Severity of symptoms: the patient's clinical presentation e.g. severe pain, fever necessitates urgent surgical evaluation. Timing: appendectomy is usually performed as soon as possible to prevent complications. Potential complications if treatment is delayed: perforation. Delay can lead to rupture of the appendix, resulting in peritonitis, a severe abdominal infection, abscess formation. A perforated appendix can lead to localized or generalized abscesses, requiring further intervention. Sepsis. The spread of infection from a ruptured appendix can lead to systemic inflammatory response syndrome (SIRS) and sepsis, posing a life-threatening risk. Increased morbidity. Delayed treatment may result in longer hospital stays, more extensive surgeries, and increased healthcare costs. Discuss the pathophysiology of ischemic heart disease (IHD) and its implications for treatment options. Include the role of lifestyle modifications in management. Answer: ischemic heart disease (IHD) results from an imbalance between myocardial oxygen supply and demand, primarily due to atherosclerosis, which leads to coronary artery narrowing. This can manifest as angina pectoris or myocardial infarction. In managing IHD, treatment options may include pharmacological approaches such as antiplatelet agents, beta blockers, ACE inhibitors, and statins, aiming to reduce morbidity and mortality. However, lifestyle modifications play a critical role. Patients are encouraged to adopt a heart-healthy diet, engage in regular physical activity, manage weight, and quit smoking. Guidelines such as the NICE National Institute for Health and Care Excellence recommend tailored exercise programs and nutritional counseling as adjuncts to medication. The overall aim is to reduce cardiovascular risk and improve quality of life. Mr. Thompson, a 62-year-old male with a history of COPD, presents to the emergency department with acute respiratory distress. He has increased work of breathing and a respiratory rate of 30 breaths per minute. What immediate management steps should the healthcare team take, and what long-term management strategies should be considered? Answer: immediate management for Mr. Thompson's acute respiratory distress should include oxygen therapy. Administer supplemental oxygen to maintain SPO above 92%. Bronchodilators. Administer short-acting beta-agonist e.g. albuterol via nebulizer to relieve bronchospasm. Corticosteroids. Start systemic corticosteroids e.g. prednisone to reduce airway inflammation. Assess for respiratory failure. Monitor arterial blood gases, eggs, and consider non-invasive ventilation if there are signs of respiratory failure. Long-term management strategies should focus on smoking cessation, encourage and facilitate quitting smoking, pulmonary rehabilitation, referral to a rehabilitation program to improve exercise tolerance and quality of life, medications, long-acting bronchodilators, LABA, and inhaled corticosteroids for maintenance therapy, vaccinations, annual influenza vaccination and pneumococcal vaccination to prevent respiratory infections. What are the common signs and symptoms of acute kidney injury, AKI, and what diagnostic criteria are used to confirm the diagnosis? Answer: acute kidney injury, AKI, is characterized by a rapid decline in renal function, typically defined by an increase in serum creatinine or a decrease in urine output. Common signs and symptoms include decreased urine output, oliguria or anuria, fluid overload, peripheral edema, pulmonary congestion, electrolyte imbalances, hyperkalemia, hyponatremia, uremic symptoms, nausea, vomiting, confusion. The diagnostic criteria for AKI are defined by the KDIGO, kidney disease, improving global outcomes guidelines, increase in serum creatinine by 0.3 mdL 26.5 umol within 48 hours, increase in serum creatinine to 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, urine volume 0.5 kg for 6 hours. Early recognition and appropriate management are crucial to prevent progression to chronic kidney disease. See Evaluate the principles of advanced cardiac life support (ACLS) in the management of a patient experiencing a cardiac arrest. What is the significance of high-quality CPR in this context? Answer: the principles of advanced cardiac life support (ACLS) during cardiac arrest focus on the immediate recognition of arrest, activation of emergency response systems, and initiation of high-quality CPR. Key components of ACLS include immediate CPR. High-quality chest compressions are vital, targeting a compression rate of 1:0.12 per minute and a depth of at least 2 inches 5 centimeters. Allow complete chest recoil after each compression. Defibrillation. Early defibrillation is critical for patients with shockable rhythms, ventricular fibrillation, or pulseless ventricular tachycardia. Airway management. Ensure airway patency and provide supplemental oxygen as needed. Medications. Administer epinephrine every 3-5 minutes during resuscitation and consider antiarrhythmic drugs such as amiodarone for shockable rhythms. The significance of high-quality CPR cannot be overstated. Studies have shown that effective CPR can double or triple a patient's chance of survival. The 2020 AHA guidelines emphasize the importance of early and effective chest compressions, minimizing interruptions in CPR, and optimizing the timing of defibrillation and medication administration. Mr. Patel, a 45-year-old man with a history of type 2 diabetes, presents to the clinic with signs of severe hypoglycemia, including polyuria and polydipsia. Discuss the potential underlying mechanisms of diabetic ketoacidosis (DKA) in this patient and outline the immediate management steps required. Answer: diabetic ketoacidosis (DKA) primarily occurs in patients with type 1 diabetes, but can also arise in patients with type 2 diabetes, particularly during periods of stress or illness. In Mr. Patel's case, potential underlying mechanisms include insulin deficiency. Insufficient insulin levels prevent glucose from entering cells, leading to hypoglycemia. Increased ketogenesis. The body shifts to fat metabolism for energy, resulting in the production of ketone bodies, leading to metabolic acidosis, dehydration. Polyuria due to hypoglycemia leads to significant fluid loss and dehydration. Immediate management steps include fluid replacement. Start with isotonic saline to rehydrate and restore circulating volume. Insulin therapy. Administer continuous IV insulin infusion to lower blood glucose levels and suppress ketogenesis. Electrolyte monitoring. Monitor serum potassium levels closely, as insulin therapy may cause potassium to shift back into cells, potentially leading to hypokalemia. Bicarbonate therapy. Only consider sodium bicarbonate if severe acidosis pH 6.9 is present. What are the distinguishing features of rheumatoid arthritis compared to osteoarthritis, and how do these differences inform management strategies? Answer: rheumatoid arthritis (RA) and osteoarthritis (OA) are two distinct forms of arthritis differing in etiology, pathology, and clinical features. Etiology: RA is an autoimmune disorder characterized by systemic inflammation, while OA is primarily a degenerative joint disease associated with mechanical wear and tear. Pathophysiology: RA involves synovitis and the formation of pannus, leading to joint erosion. In contrast, OA involves cartilage degradation and bone remodeling without significant synovitis. Clinical features: RA typically presents with symmetrical polyarthritis, morning stiffness lasting more than an hour, and systemic symptoms fatigue, fever. OA presents with joint pain and stiffness that worsen with activity and improve with rest, often affecting weight-bearing joints asymmetrically. Management strategies differ. RA requires disease-modifying antihepatic drugs, DMARDs such as methotrexate, along with NSAIDs for symptomatic relief and corticosteroids for flare-ups. OA focuses on lifestyle modifications, exercise, weight loss, analgesics, paracetamol, NSAIDs, and intra-articular corticosteroid injections, with surgical options considered for advanced cases. NIC Guidelines outline the management pathways for both conditions, emphasizing a patient-centered approach. Explain the role of prophylactic anticoagulation in the management of patients at risk for thromboembolic events. What guidelines support these practices? Answer: prophylactic anticoagulation is crucial in managing patients at high risk for thromboembolic events, particularly in postoperative settings, patients with prolonged immobility, or those with a history of venous thromboembolism (VTE. The primary role of anticoagulants, such as low molecular weight heparin or fondaparinux, is to prevent the formation of blood clots. Key considerations include risk assessment. Tools such as the Padua Prediction Score or the Caprini Risk Assessment Model help identify patients needing prophylaxis. Duration of prophylaxis. Guidelines recommend initiating prophylaxis as soon as feasible postoperatively and continuing for an appropriate duration based on individual risk factors. Evidence from the American College of Chest Physicians Act guideline supports the use of pharmacological prophylaxis, particularly in high-risk surgical patients and those with significant medical comorbidities. The overall aim is to reduce the incidence of DVT and pulmonary embolism, improving patient outcomes and safety. Describe the pathophysiology and management of hyperkalemia in patients undergoing renal replacement therapy. Answer: hyperkalemia is a common electrolyte disturbance in patients with renal failure characterized by elevated serum potassium levels, which can lead to life-threatening cardiac arrhythmias. The pathophysiology involves reduced renal excretion, impaired kidney function decreases potassium excretion, tissue breakdown. Conditions such as rhabdomyolysis or hemolysis can release intracellular potassium. Medications. Certain drugs, GAC inhibitors, potassium-sparing diuretics, can exacerbate hyperkalemia. Management includes immediate assessment, monitor ECG for changes indicative of hyperkalemia, PET T waves, the stabilization, administer calcium gluconate or calcium chloride to protect the myocardium. Shifting potassium, use insulin and glucose to drive potassium back into cells and consider nebulized base agonists. Removal, initiate dialysis to remove excess potassium from the body. Discuss the psychosocial aspects of chronic illness management, particularly in the context of diabetes care. How can healthcare providers support patients in this regard? Answer: chronic illness management, particularly in diabetes care, involves significant psychosocial components, including emotional distress. Patients may experience anxiety, depression, or diabetes-related distress, which can hinder self-management. Health beliefs. Patients' perceptions of their illness and its impact on their lives can influence adherence to treatment and lifestyle modifications. Healthcare providers can support patients through patient education, providing clear, accessible information about diabetes management and the importance of adherence to treatment plans. Psychological support, offering referrals to mental health professionals or support groups to address emotional challenges. Motivational interviewing, utilizing techniques to enhance patient motivation and empower them to set realistic goals. Shared decision-making, engaging patients in their care decisions to foster a sense of ownership and accountability. What are the key differences between type 1 and type 2 diabetes mellitus in terms of pathophysiology, clinical presentation, and management? Answer: type 1 and type 2 diabetes mellitus have distinct pathophysiological mechanisms, clinical presentations, and management strategies. Pathophysiology: type 1 diabetes. An autoimmune destruction of pancreatic beta cells leads to absolute insulin deficiency. It often presents in childhood or adolescence. Type 2 diabetes, characterized by insulin resistance combined with relative insulin deficiency, it typically develops in adults, often associated with obesity and sedentary lifestyle. Clinical presentation. Type 1. Patients may present with polyuria, polydipsia, weight loss, and diabetic ketoacidosis. Type 2. Symptoms may be subtle. The patients often present with polyuria, polydipsia, and fatigue and may have comorbid conditions like hypertension and dyslipidemia. Management. Type 1 requires lifelong insulin therapy. The focus is on tight glycemic control with the potential use of insulin pumps and continuous glucose monitoring. Type 2 managed through lifestyle modifications, diet and exercise, oral hypoglycemic agents, e.g. metformin, and may require insulin as the disease progresses. The Diabetes UK guidelines highlight the importance of individualized care strategies based on the type of diabetes and patient preferences. What is the primary purpose of applying evidence-based guidelines in patient care, and how can a clinician assess their validity and applicability? Answer: the primary purpose of applying evidence-based guidelines in patient care is to improve patient outcomes by integrating the best available research evidence with clinical expertise and patient values. Clinicians can assess the validity and applicability of guidelines by evaluating the following criteria: quality of evidence. Guidelines should be based on systematic reviews of high-quality studies, including randomized controlled trials (RETS) and meta-analyses. Clinicians should look for grades of recommendation, which classify the strength of the evidence. Population and context. Clinicians must consider whether the study populations in the guidelines reflect their patient demographics. If the guideline is based on a population that significantly differs from the clinician's patients, its applicability may be limited. Clinical significance. Assess the clinical significance of the results, not just statistical significance. This involves considering the effect size and whether the outcomes are meaningful in the context of patient care. Confounding factors. Clinicians should be aware of potential confounding factors that could affect the study's outcomes and how these factors may be controlled. Consensus. Consider guidelines endorsed by reputable organizations, e.g., NICE, that represent a consensus among experts in the field. Guidelines, such as those from NICE or the BMJ, are formulated with the aim of reducing variability in clinical practice and improving patient safety, and clinicians should actively engage in evaluating their relevance to specific cases. Discuss the critical steps involved in the clinical problem-solving process when faced with a patient presenting with red flag symptoms. Answer: when a clinician encounters a patient with red flag symptoms, the clinical problem-solving process involves several critical steps. Recognition of red flags. Clinicians must be familiar with red flag symptoms, which indicate potential serious underlying conditions, e.g., unexplained weight loss, severe pain, neurological deficits. Detailed history and examination. Conduct a thorough patient history and physical examination to gather relevant information about the presenting symptoms, past medical history, and any alarming signs. Differential diagnosis. Develop a list of potential diagnoses, prioritizing those that align with the red flag symptoms. This may include serious conditions such as malignancies, fractures, or infections. Investigative workup. Determine the necessary investigations, e.g., imaging, lab tests to confirm or rule out potential diagnoses. The clinician should consider the urgency of obtaining these results, especially for red flag presentations. Referral and management. If the red flag symptoms suggest a serious condition that cannot be managed in primary care, prompt referral to a specialist is critical. The clinician must also provide interim management strategies for symptomatic relief. Follow-up. Establish a follow-up plan to reassess the patient, especially if the symptoms persist or worsen. This may involve repeated evaluations and further investigations as required. Applying clinical guidelines related to urgent referrals, such as the NICE guidelines on back pain or abdominal pain, is essential to ensure timely intervention and optimal patient outcomes. Mr. Thompson, a 60-year-old male with a history of hypertension and smoking, presents with sudden onset chest pain radiating to his left arm. What immediate steps should you take to manage this situation? Answer: in managing Mr. Thompson's presentation, the following immediate steps should be taken. Initial assessment. Conduct a rapid assessment using the ABCDE approach: airway, breathe-in, circulation, disability, exposure. Ensure that Mr. Thompson's airway is clear, assess his breathing and circulation status, and check for any signs of neurological deficit. Vital signs monitoring. Obtain vital signs, including heart rate, blood pressure, respiratory rate, and oxygen saturation. An electrocardiogram should be performed immediately to assess for any acute ischemic changes, such as segment elevation or other abnormalities indicating myocardial infarction. Call for help. Given the high risk of acute coronary syndrome, activate the emergency response system for further assistance and preparation for potential resuscitation. Supplemental oxygen. Administer supplemental oxygen if the patient is hypoxic, SPO 94%. Aspirin administration. Administer aspirin, typically 300 mg, unless contraindicated, e.g., allergy or active bleeding. Aspirin is crucial in reducing platelet aggregation in the case of myocardial infarction. Nitrates. If no contraindications exist, e.g., hypotension, consider administering nitrates to relieve chest pain and improve coronary blood flow. Transport. Prepare for rapid transport to the nearest hospital equipped for cardiac emergencies. Continuous monitoring should be established during transport. Documentation. Document all findings, interventions, and patient responses thoroughly in the patient's medical record for continuity of care. These steps follow the guidelines set out by the National Institute for Health and Care Excellence (NICE) for the management of chest pain and suspected ACS. What are the principles of critical appraisal in the context of assessing the validity and reliability of clinical trials? Answer: critical appraisal involves a systematic approach to evaluating the quality and applicability of clinical trials. The principles include study design. Assess whether the study design, e.g., RCT cohort case control, is appropriate for answering the research question. RCTs are generally the gold standard for establishing causality, population and sample size. Evaluate the inclusion and exclusion criteria for study participants to determine if the population is representative. A sample size calculation should confirm that the study is adequately powered to detect meaningful differences. Randomization and blinding. Examine the methods of randomization and blinding to reduce bias. Proper randomization minimizes selection bias, while blinding reduces measurement and performance biases. Outcome measures. Ensure that the outcome measures are clearly defined, valid, and reliable. Composite outcomes should be assessed to confirm that they accurately reflect patient-relevant endpoints. Data analysis. Analyze whether the statistical methods used are appropriate and clearly reported. Look for potential confounders and how they were controlled. Results reporting. Assess the reporting of results, including adverse events, to provide a complete picture of the intervention's safety and efficacy. Relevance to clinical practice. Finally, consider the applicability of the trial findings to the local population and clinical settings. This includes evaluating whether the intervention is feasible and aligned with current practice guidelines. By adhering to these principles, clinicians can ensure that they utilize reliable evidence in their practice, contributing to improved patient outcomes and quality care. Explain the process of managing complex multi-system diseases and the significance of interdisciplinary collaboration in such cases. Answer: managing complex multi-system diseases necessitates a structured approach that emphasizes comprehensive assessment. Begin with a detailed patient history and physical examination, focusing on symptoms related to multiple organ systems. Utilize relevant diagnostic tests to assess the extent of the disease. Interdisciplinary team formation. Form a team comprising specialists from various disciplines relevant to the patient's conditions, e.g., cardiology, nephrology, endocrinology. Each specialist brings unique insights and expertise, facilitating comprehensive care. Developing a management plan. Collaboratively develop a management plan that addresses all aspects of the patient's health. This plan should be patient-centered, taking into consideration the patient's values, preferences, and social circumstances. Regular communication. Ensure ongoing communication between team members to discuss the patient's progress, address emerging concerns, and modify treatment plans as needed. This fosters a coordinated approach to care. Patient education and support. Provide education to the patient regarding their conditions and treatment options. Involve family members or caregivers to create a supportive environment that enhances adherence to the management plan, follow-up, and reassessment. Schedule regular follow-ups to monitor disease progression and treatment effectiveness. Adjust the management plan as needed based on the patient's evolving health status. The significance of interdisciplinary collaboration lies in its ability to leverage diverse expertise, reduce care fragmentation, and improve patient outcomes, particularly in complex cases where multiple conditions coexist. How can a clinician effectively utilize clinical guidelines to manage a patient with complex medical needs? Answer: to effectively utilize clinical guidelines for managing a patient with complex medical needs, a clinician should identify relevant guidelines, determine which guidelines pertain to the patient's specific conditions. This may involve accessing guidelines from reputable sources like NIC, WHO, or specialty-specific organizations. Adaptation to individual cases. Tailor the application of guidelines to the individual patient's context, considering comorbidities, personal values, and preferences. This requires clinical judgment and an understanding of the patient's unique situation. Integrating evidence with clinical expertise. Combine the recommendations from the guidelines with personal clinical experience and expertise to develop a holistic management plan. Communicate with the patient. Discuss the guidelines and management plan with the patient to ensure their understanding and agreement. Engaging the patient in the decision-making process fosters adherence and satisfaction. Continuous monitoring and adjustment. Regularly reassess the patient's condition and treatment response, adjusting the management plan based on guideline updates, patient feedback, and new evidence as it emerges. Documenting the process. Maintain thorough documentation of the clinical decision-making process, including references to specific guidelines, to ensure continuity of care and legal protection. By following these steps, clinicians can provide evidence-based, patient-centered care while adhering to best practices in the management of complex medical needs. What role does bias play in the interpretation of clinical trial results, and how can clinicians minimize its impact? Answer: bias can significantly distort the interpretation of clinical trial results, leading to incorrect conclusions about the efficacy or safety of interventions. Bias may arise from various sources, including selection bias, occurs when the participants included in the study are not representative of the broader population. This can happen if specific inclusion-exclusion criteria are too stringent or if there's non-random allocation. Performance bias arises when there are differences in care between treatment groups beyond the intervention itself. This can be minimized by blinding participants and investigators to the intervention. Detection bias occurs when outcome assessors are aware of the treatment allocation, leading to differential assessment of outcomes. This is addressed through blinding assessors to treatment groups. Attrition bias results from differential dropout rates between treatment groups. High attrition can skew results, and researchers should report dropout rates and analyze the reasons for dropouts. To minimize the impact of bias, clinicians should critically appraise studies for potential biases before drawing conclusions, evaluate the robustness of the methodology and the findings, considering whether the biases could have altered the results meaningfully, utilize systematic reviews and meta-analyses that aggregate data from multiple studies to provide a more balanced view, thus reducing the influence of individual study biases. Understanding these concepts is crucial for clinicians to interpret clinical trial results accurately and to apply findings appropriately in their practice. Mrs. Carter, a 55-year-old woman with a history of chronic obstructive pulmonary disease, COPD, presents to the emergency department with worsening shortness of breath and a productive cough with green sputum. What clinical guidelines should you consider, and what immediate management steps should be taken? Answer: in managing Mrs. Carter's presentation of worsening shortness of breath and productive cough, the following clinical guidelines should be considered, specifically those from NIC and BTS regarding COPD exacerbations. Assessment: conduct of rapid assessment using the ABCDE approach to evaluate Mrs. Carter's vital signs, oxygen saturation, and level of consciousness. Oxygen therapy: administer supplemental oxygen to maintain SPO levels between 88% and 92%, monitoring closely for any increase in co-retention due to her COPD. Bronchodilators: provide nebulized short-acting bronchodilators e.g. salbutamol as per guideline recommendations for acute exacerbation management. Corticosteroids: administer systemic corticosteroids e.g. prednisolone to reduce inflammation and improve recovery times as suggested by guidelines. Antibiotics: given the productive cough with green sputum, initiate antibiotics e.g. amoxicillin or doxycycline if the clinical suspicion of bacterial infection is high, following the principles outlined in the guidelines regarding acute exacerbations of COPD. Monitor Mrs. Carter's response to treatment closely, reassessing her respiratory status and adjusting management as necessary. Patient education: once stabilized, educate Mrs. Carter about recognizing signs of exacerbations and appropriate action steps, emphasizing the importance of adherence to her COPD management plan and regular follow-up appointments. By adhering to these steps, clinicians can effectively manage COPD exacerbations while following best practice guidelines, which are crucial for optimizing patient outcomes. Explain the significance of recognizing red flag symptoms in clinical practice and how this impacts patient management strategies. Answer: recognizing red flag symptoms is vital in clinical practice for several reasons. Indication of serious conditions: red flag symptoms often signify underlying serious or life-threatening conditions, e.g. malignancy, fracture, or vascular emergencies. Early recognition facilitates timely intervention, which is crucial for favorable patient outcomes. Guiding referrals: identification of red flag symptoms prompts clinicians to initiate appropriate referrals to specialists or emergency services, ensuring that patients receive the necessary urgent care. Risk stratification: by recognizing red flag symptoms, clinicians can stratify patients based on risk, enabling them to prioritize those who require immediate attention and those who can be managed in a more controlled setting. Improving clinical decision-making: awareness of red flag symptoms enhances clinical decision-making by providing a framework for further assessment, investigations, and treatment planning. Patient safety: ultimately, recognizing red flag symptoms significantly improves patient safety by minimizing the risk of misdiagnosis or delayed treatment, which can lead to worsened outcomes. clinicians should regularly review and update their knowledge of red flag symptoms in various clinical contexts to ensure the effective application of this knowledge in practice. What strategies can clinicians employ to enhance their critical thinking skills when interpreting research data from clinical studies? Answer: clinicians can employ several strategies to enhance their critical thinking skills when interpreting research data, including structured approach, use frameworks such as PICO, population intervention comparison outcome, to formulate questions and guide the analysis of research data, regular engagement with literature, stay updated with the latest clinical research by subscribing to relevant journals, attending conferences, and participating in journal clubs to discuss findings with peers. Reflective practice. Engage in reflective practice by critically assessing one's clinical decisions, identifying areas for improvement, and integrating new evidence into practice. Training in biostatistics. Pursue training or courses in biostatistics to enhance understanding of statistical methods, enabling clinicians to evaluate the validity and reliability of study results more effectively. Collaborative learning. Foster interdisciplinary collaboration with colleagues from research backgrounds, facilitating a shared understanding of evidence interpretation and application.